Good afternoon, everybody. We are going to start the plastics sessions again. And our speaker is Tom Betts. He's a consultant oculoplastic surgeon in University Hospital of Wales. Over to Tom to start the lecture.
Hi, everyone. My name is Tom Betts. I work at University Hospital of Wales in Cardiff. And today I'm giving hopefully a comprehensive update on periocular skin cancer for you. I'm aware there's a big variety of seniorities in the room, from junior doctors through to experienced oculoplastic surgeons, so hopefully there's something in here for everybody. So of course, periocular skin cancer means a skin cancer in the periocular region. It's of importance because of the limited tissue that's available in the region, and also due to the proximity of vital structures, the globe itself, the sinuses, the brain. Grossly, there are 5 major types of skin cancer that we see: basal cell carcinoma, squamous cell carcinoma, melanoma, sebaceous gland carcinoma, and the Merkel cell carcinoma. So when we think about the incidence of these tumours that I see in my sort of current practice, so the basal cell carcinoma makes up the majority of the work. So 90% of periocular skin cancer will be basal cell carcinomas. Squamous cell carcinomas make up the majority of the other 10%. They are obviously less common but more aggressive with that metastatic potential. Melanomas are rare. I see probably 1 case every year. And then sebaceous gland carcinoma, Merkel cell carcinoma, are extremely rare. You maybe see 1 or 2 in your career. The risk factors for these are, for all skin cancers, UV radiation exposure is number 1, and then increasing age with the cumulative effect of UV radiation. Some patients will have a genetic predisposition, generally things like xeroderma pigmentosa, Gorlin-Gault syndrome, and any patient who has a previous history of skin cancer will have a 20% risk in the next 5 years of developing a second skin cancer. So looking a bit more at that pathophysiology, so there's UV-induced DNA damage to results in genetic mutations such as PTH1 and BCCs. You've got BRAF mutations in melanomas, things of this nature, P53 in squamous cells, etc. In addition to that, we see a lot of patients who are immunosuppressed, so renal transplant patients particularly, who've had transplant 20 years ago, and then over fullness of time, that combination of UV damage and immunosuppression results in a high risk of squamous cell carcinomas. With regards to progression, when left untreated, of course, we get local invasion with spread to the eyelids, the orbit, paranasal sinuses, and our squamous cells, melanomas, etc., pose a risk of metastasis. Of course, generally speaking, basal cell not. So looking at the clinical presentation, so there are very unifying signs and symptoms, really. We get nodular growths, ulcerations, essentially lesions around the periocular area, of course, common for all these things. We get changes in the skin colour or texture around the eyes, and some patients may report possible changes in the vision and discomfort, and it depends, of course, of where the location of the tumour is. It's important to take note that any pigmented lesion, we must at least consider melanoma. The differential diagnosis will include benign lesions like chalasia and papillomas, and malignant conditions like lymphoma. Here are just a couple of examples of cases from Wales. So here we can see that classic basal cell carcinoma, telangiectasic surface, raised edges, pearled appearance. Sometimes we see the lash follicle destruction, but of course not in this case. There may be ulceration at the centre. We can see cyst formation. And the patient will often report that there's bleeding with just light touch of the lesion. Here's a classic example of a squamous cell carcinoma with that classic hyperkeratosis, ulceration in the centre, scaliness. With regards to the history, when we compare the basal cell to the squamous cell often is presenting much more rapidly. The basal cells are fairly insidious, progressing over years. Finally, malignant melanoma, an example of a left lower lid here with pigmentary changes of varying degrees across the lower lid with loss of lashes and also some irregularity of the lid margin, so fairly classic for a lower lid melanoma. We use the ABCDE method when assessing pigmentary lesions, so asymmetry, so one half doesn't match the other, irregular borders, color variation, so shades of black, brown, reds, and blues. The diameter is generally greater than 6 millimeters, but this is not always the case, so we have some very astute patients who may present very quickly and have very small melanomas at presentation. Evolution from pre-existing moles is about 1/3 of cases, so the majority of melanoma arises from previously normal skin. When we think about the diagnostic approach, I'm very lucky that I work hand in hand with a dermatologist, so all patients will get a detailed ophthalmic and also dermatologic evaluation with dermacoscopy, and also a slit lamp examination. With the clinical examination in the history, we generally have a good feeling for what the tumor is, and so we can usually perform excisional biopsy of some form, but in some cases where the diagnosis is uncertain, incisional biopsy does have a role, and subsequent histopathological examination. For cases where we're worried about metastatic disease, staging, local deep invasion, MRI, CT, ultrasound will all have potential roles in further assessment of the patient. This is one of my dermatology colleagues, Rachel Abbott in Cardiff. I certainly am much more of an expert in histopathology than myself, but just for completeness, a couple of histopathology slides. So here we see basal cell carcinoma with the classic features of the peripheral palisading around the edge. Palisading is like the white picket fence around the American houses, so this is the hallmark feature with that peritumoral clefting or retraction artifact, as it's also described around the tumor itself. Squamous cell carcinoma here we can see with the typical features in a well-differentiated squamous cell carcinoma of keratin pearls and then pleomorphic vesicular nuclei, etc. Finally, we can see an example of melanoma from a histopathological perspective. The melanocytes are usually in the basal layer of the epidermis, and then here we can see there's been a spread horizontally first in the dermis and then vertically through the dermis into subdermal tissue. So there have been many recent advances when it comes to skin tumors, their diagnosis, and how we look after these patients, principally in the context of molecular diagnostics, so the identification of genetic mutations. So as mentioned before, things like BRAF in the melanomas will help guide what treatments are appropriate for a patient, and also for differentiation between basal cells and squamous cells. For example, our pathologists will use specific immunohistochemistry markers like CK10. Artificial intelligence has got an increasing role in the diagnosis of skin cancers. I've got to be honest that in Wales we're very backward with regards to our referrals, so we still rely on colour photographs and sometimes, sadly, just black and white photographs. But in dermatology fields, we're using artificial intelligence increasingly to help with the triaging of referrals so that it frees time for the clinician to be better used in operating and looking after patients. Of course, there are questions about the validation of AI, and it's a novel technology, but I think it's here to stay and something we're going to have to embrace to make better uses of our limited resources. Finally, with regards to advances, optical coherence tomography is something we're very aware of in retinal and anterior segment disease, but it's also now having some purchase in the management of skin cancer. So I thought I'd look at this in a little bit more detail because it's quite interesting. So what role does it play? So OCT has been well proven now to be very accurate and more sensitive at diagnosing basal cell carcinoma in particular versus just clinical examination, standard clinical examination. It's useful, therefore, for differentiation between benign and malignant lesions. And where we've got tumours that are sort of fairly innocuous and it's hard to know where to do a biopsy maybe, you could use the OCT to guide you for an area that's likely to have a high yield of tumour cells and perform biopsy over this. So these are sort of roles that OCT may lead to in the future. For patients who don't want surgery or it's not appropriate, it could be used for non-invasive monitoring. And then also, because it's very sensitive in a patient where we've excised a basal cell carcinoma, for example, if you want to survey them in the future or look at the treatment response, it's been much more sensitive for picking up recurrences versus just our standard clinical examination. This is a little example of OCT being used in a patient with a basal cell carcinoma. And the key feature that they report is that you get these signal-free cavities, and those are delineated within the dotted red areas there. So there's obviously going to be user experience required to get good at using OCT to diagnose basal cell carcinoma, etc., but it certainly looks like a useful modality. So the advantages are that it's non-invasive, it's high resolution and real-time imaging, but the limitations are that OCT does have quite limited depth. So there's ongoing studies right now, certainly in London, where they're using OCT in conjunction with other modalities, so we can get the breadth and the depth on a tumor. And so this could be a useful modality for the future. As I've said, there's going to be operator dependency issues and also cost and accessibility. So when I heard about OCT in skin cancer, I thought, great, I've got an OCT in my room, it's going to be really helpful, but unfortunately it is pretty limited. For skin, you have to have handheld OCT to do it usefully. So, moving on to treatment. So as we discussed at the roundtable today, really Oculoplastics lends itself to a multidisciplinary team. And the team that I currently work within, which I think is pretty standard, is a dermatologist, ophthalmologist, plastic surgeon, maxillofacial surgeon, and oncologists, pathologists, radiologists, and we have a team of specialist nurses from both dermatology and oculoplastics. And as a team, our goals are to get complete tumor removal, preservation of vision and ocular function, and an optimal aesthetic outcome. So I moved to Wales to become a consultant in 2020, and this is a little summary of some of my experiences. So we offer this joint service now for 4 years of dermatology and ophthalmology each week, where we alternate between clinic and surgical weeks, basically. We also offer an alternate virtual skin MDT that's attended by the entire team. And over the past 4 years, we've done approximately 400 Mohs cases. An example, 2021, we did 90 Mohs cases overall, so some are just head and neck. 63 were periocular. All of these cases were repaired on the same day, so this is maybe slightly atypical, where Mohs cases are usually excised, and then the patient has delayed reconstruction 1-2 weeks later. We repair on the same day. And in the past 4 years, we've only had one case which required transfer from dermatology to main theatres, where we need to harvest some hard palate for posterior lamellar reconstruction. So overall, anecdotally, there's been a big improvement in the patient experience, with it being a one-day complete surgical package. It's really strengthening the collegial relationships by working alongside dermatology, etc. I personally have learned a vast amount from them. It reduces the pressure of theatre demands and the cost associated to that. But there's definitely potential for future refinement. At present, our preoperative stage is fairly clunky, but it's certainly a work in progress that we think is overall going very well. So as I've alluded to, Mohs micrographic surgery is what we offer to the vast majority of our patients, because most of our patients have basal cell carcinoma, and it's the gold standard for BCC and SCC. Now, SCC is for us a bit contentious because we haven't currently got a system that can deliver very quick Mohs surgery, so most squamous cell carcinoma actually has excisional surgery for myself, as do melanomas and the other rarer tumours. To talk a bit more now about Mohs surgery, for those who aren't aware, this is Frederick Mohs. He's an American plastic surgeon. And in 1969, he reported 66 eyelid cases of basal cell and squamous cell carcinoma with a 5-year cure rate of 100%. And on the back of this work, Mohs surgery really took hold and is, as I say, become the gold standard for tumour care with basal cells and squamous cell. For those who haven't seen much Mohs surgery, it's pretty similar to standard excision, apart from rather than giving a margin, we keep it quite close to the tumour, and we take a much more beveled edge. The reason being that entire cut surface is then laid down on a histopathology slide, and the entire surface can be assessed to see if there's any presence of tumour. And that is sort of in comparison to conventional excision, where you may take an ellipse. The tumour is then sliced like a loaf of bread, and only a very small proportion of the tumour is actually assessed. And so there is potential with the conventional techniques to miss extension of tumour beyond the edge of the cut margin. So this is the key difference, is that all the surface gets examined using the Mohs technique. And this is kind of a typical patient journey. Here's a patient with a basal cell on their cheek. It's been marked with a narrow margin. It's been excised. By the final photograph on the top right there, we can see that we've identified there's still some positive margin, so further tumours excised there. And that sort of process is repeated until the entirety of the tumour is removed. As I've said, the benefit to Mohs surgery in our centre is that it's a single visit outpatient surgery. It examines 100% of the tumour margins and its tissue sparing. We see 99% cure rates for skin cancer that have not been previously treated, and 94% cure rates for skin cancers that have had a previous treatment and therefore it's a recurrence when they present to ourselves. The disadvantage, as I've alluded to, is the long waiting time. So sadly, we have about a 6-month wait for Mohs surgery in Wales. And it is a long day for patients. They tend to arrive 9 o'clock in the morning. By midday, they've had all the stages of excision, and then they start reconstruction. It can go on into the early afternoon, into the evening. Periocular reconstruction is something that I find really enjoyable, and so I've got a few slides on this. Just some background, basic revision for everybody. The lid is a bilamellar structure, as I'm sure we'll all recall. The anterior lamella is the orbicularis in the skin, the posterior lamella being the tarsal plate and the conjunctiva, and the grey line dividing the two. It's important to remember about the bilamellar structure because when we come to do full thickness reconstructions, at least one of the lamellae has to have a blood supply traditionally for that graft to take. That's the classical teaching. With regards to maybe 3 common techniques I thought would be worth touching on for the junior members of the audience, we do a lot of direct closure. The rhomboid flap's very useful, and we do quite a lot of tarsoconjunctival flaps. So direct closure, as we'll remember, of course, from just simple trauma repairs, I tend to do a grey line suture first, or meibomian gland suture, followed by some buried tarsal plate sutures, maybe some 5-0 vicryl, something of this nature, a lash line suture to get the best cosmesis, reflect that down onto the skin, and then incorporate those long sutures into skin sutures. It's a really very basic technique that's been around for a long time, but I find it to be something that's very robust. I haven't had, with any luck, any dehiscences of this technique, and maybe some of my junior colleagues have tried some more novel things with buried sutures, and maybe haven't had the same result. So I stick to a really robust, simple closure for my direct closure patients. Just a nice, simple example of a patient with a full-thickness defect. Of course, it's not involving the entire height of the tarsus, so a bit more tarsal plate has to be removed so we don't get buckling when it's closed directly. So next we have a rhomboid flap. The rhomboid flap's been used in plastics for a long time. For people who like Star Wars, you may remember the TIE fighter. So this central section of the spaceship is like your lesion. You've got a defect to fill. And then you can draw incisions horizontally or laterally from your wound. And then there's either a vertical or a inferior incision made to create your rhomboid flap. Now, in the presence of oculoplastics, of course, we can't really go laterally because we've got a globe. And so we tend to have our defect to the medial canthus. We make a horizontal incision towards the midline, and then a vertical incision is usually used to try and harvest some of that redundant skin in the glabella to drop into the defect. So here's an example, again, from Cardiff. Sorry about all the scribbling. It was a teaching case with the registrars. But you can see the typical incision we make horizontally, and then a vertical oblique limb. And then that, with a good amount of undermining, drops nicely into the defect, and the patient will heal well. Finally, from a reconstruction technique, the Hughes flap. So this is Wendell Hughes, and he describes this flap in 1937. He's a Canadian working in New York. And he describes the Hughes flap as tarsoconjunctival flap, ideal for 30 to 75% lower lid loss. The reason I make this point is that increasingly myself and colleagues, certainly in the UK, are using tarsoconjunctival flaps to repair upper lid defects. So if you've got at least 50% of an upper lid, you can do a really nice tarsoconjunctival flap, slide it either medially or laterally, and create a really nice posterior lamella in that fashion, and therefore not requiring things like cutler beard, which is a fairly less than ideal surgery, we think. So tarsoconjunctival flap is really flexible option. And the idea is that we're going to take a vascularized piece of upper lid tarsal plate and then place that down into your defect, leave it on a pedicle, and then put a full thickness skin graft on top of that. At a later date, then we can divide the pedicle and hopefully have a nice result. So this is an example from Wales of one of our anaesthetic colleagues who had a basal cell carcinoma, and let me take some photographs through his surgery. So we can see it's a lower lid defect, approximately 50%. We've averted the upper lid with a traction suture and then make our appropriate tarsal plate harvest on a pedicle that's then placed into the defect and sits and sutured into place. A full thickness skin graft is placed on the surface, and then they come back, in my practice, 2 weeks later. There's a lot of, it's a bit contentious when you divide your pedicle. I do 2 weeks because it falls nicely for me, just from a practical perspective for theatre access. I had some colleagues in New Zealand who did it 3 days, which seems very quick. I know in America people can leave it for several months. I find that 2 weeks is perfectly adequate. I haven't had any failing at this stage. And then so we divide it at the 2 weeks period, and at this stage it's looking pretty nice. I tell my patients that it's all a 3-stage process, a Hughes flap or tarsoconjunctival flap. The reason being that we do the surgery on day 1, we divide as stage 2, and I always leave them a bit proud because then about 3 to 6 months down the line, take a hot tip cautery and just really refine the contour of that graft, and I think that gives the nicest aesthetic outcome if you give them that extra stage, once it's fully settled in. So that's a bit about reconstruction, but it sort of ignores what I think is the elephant in the room, because when I was a junior consultant, I was very keen to try and use all my skills and do as much reconstruction as possible. But over time now, I've become much more hands-off and do much more laissez-faire for lower lid cases and medial canthal cases. And this is a paper by a colleague from North Wales. And just to summarise what he says with regards to laissez-faire. So all those involved in periocular reconstruction should be fully conversant with all the techniques. However, we're doing our patients a disservice if we try and reconstruct all defects. And then with regards to his laissez-faire approach, so he states that while healing takes place, an occlusive dressing is put on for 48 hours, infection virtually never occurs, and the vast majority heal very well. And so this is what I do. I cover the wound in chloramphenicol ointment, I occlude it for 48 hours, and I take it down, and the patient just keeps it moist with chloramphenicol twice a day until the wound is fully healed. The only caveat I give a patient when they choose to have laissez-faire, because I give them all the options, I show them pictures, and they choose what they want, is that if it doesn't heal nicely, and if we find in a month's time or 6 months we haven't got an aesthetic outcome that we're happy with, we can always do reconstructive surgery at this point in time to get a better outcome, we hope. So an example from when I was a fellow in New Zealand, this is a farmer. He didn't want to have a Hughes flap and have his work inhibited, so he elects to have laissez-faire approach. He comes back at 6 weeks, and I think it's healed really nicely with good apposition of the lid, and really you'd be hard-pushed to say the patient had any previous surgery. Maybe more extensive defect here of a lower lid of a lady in Wales, lost the entire lower lid to squamous cell carcinoma. I did a small, just little plication suture in the skin laterally, but she comes back at 4 weeks. We can still see dissolvable sutures there, and really this is far superior to any reconstruction I could do, and so sometimes doing nothing is better for patients. Moving on to our non-surgical options and also recent therapeutic advances. So radiation therapy has been around for 100 years. It still has a role. It's useful for inoperable tumours in recurrence and for some patients who just do not want to have surgery or not fit enough to have surgery. So radiation still has a role. With regards to recent therapeutic advances, we've now got targeted therapies and immunotherapies. Targeted therapies work by blocking signal pathways in abnormal cancer cells. Immunotherapy enhances the body's immune response against the cancer cells. So these are sort of drugs that I'm sort of working with and our oncologists are working with. So vismodegib is a hedgehog pathway inhibitor, part of the PTCH pathway that's present in basal cell carcinomas. Vismodegib used to be funded in the UK for lots of basal cell carcinoma, then the funding was withdrawn because a lot of patients have quite significant side effects with GI upset, paresthesia. So it wasn't proven to be cost effective. But I still get vismodegib on a named patient basis for people who've only got one eye and an inoperable tumour. I find that these patients are obviously very motivated not to lose that only eye. And so over the past 4 years, maybe 5 or 6 patients are on vismodegib for about 6 months to 12 months. They've all tolerated it really well because I think they're a motivated patient cohort. And I've got a nice example to show you after this. The oncologists use targeted therapies for BRAF mutations like bemurafenib, there we are, and also immunotherapies. So pembrolizumab is probably the immunotherapy that most of our melanoma, advanced melanoma patients go on to in the UK. It's revolutionized melanoma care. So we have patients with metastatic melanoma started on pembro, and they can see complete resolution of the tumor. So it's unbelievable, some of the results. We now are having a few patients enrolled on cemiplimab with advanced periocular SCC. It's a trial that's ongoing in South Wales and across the world. So, it's certainly a treatment that's likely to catch on in the future. This is my example, one of my examples of the role of vismodegib. So this is a chap who presents late. He's an only-eyed patient, other eyes lost to a childhood injury. It's an artificial eye, so no perception light other side. It's his only eye. He presents late because he's worried. And you can see he's lost the entirety of his lower lid. He's got conjunctival globe involvement there. I did an incisional biopsy, came back as basal cell carcinoma. And we started on vismodegib after funding. And at 6 months, I think he's done really very well. We've got complete resolution of the tumour. He stopped his medication at 6 months, and he's now 2 years treatment-free. And he's clinically and radiologically free of basal cell carcinoma. So an excellent outcome for him. With regards to our prognosis, the tumour size, the location, the histological subtype, the presence of perineal invasion, and if it's recurrent disease will all play a factor in the outcome. But overall, basal cells, of course, have a high cure rate with early intervention. Squamous cell carcinoma can have a high cure rate, of course, as well, but there is that risk of metastasis. We do need our patients to present quickly. Melanoma prognosis really does depend on depth and early detection as well. Follow-up, I think, is a bit contentious. Once you've had Mohs surgery, the chances are that you're not going to get recurrence. But our standard practice for periocular Mohs cases is still to see them for 5 years. That's a departmental decision. But I think there's a lot of variability across the world. Because 20% of these patients will get a secondary tumour, I guess there is some validity in seeing them in the long run, but these tumours are fairly easy to see, and so you'd hope the patients represent themselves if they see new changes. So what are the challenges in the future directions? So for us in the UK, we stopped smoking pretty much, but we still have patients who love to burn themselves on the beach, like this lady. And so we've got an increasing population increasing population of young patients with basal cell, squamous cell, and melanoma, unfortunately. And so managing this increasing cohort of patients with our limited resource is going to be a huge challenge. It's exciting to see these advances in personalised medicine, and new therapeutic targets like gene therapy will be coming in the near future. And of course, if we have to engage with our new diagnostic tools to try and utilise our resources to the best availability. So I'd say the takeaway for myself today would be the importance of early detection and the upskilling, of course, for our community healthcare providers, GPs, etc., so we get early referrals. The importance of a multidisciplinary care approach when managing these patients. The advances in molecular diagnostics, both from a diagnostic perspective, but then also the subsequent treatment options for a patient. Most micrographic surgery remains the gold standard for your basal cell carcinomas and squamous cell carcinomas where it's available. And whilst we all enjoy operating, that's why we chose this career, there is something to be said in doing no surgery and letting the patient heal by themselves in some cases. Systemic therapies are with us, and they're only going to expand, and it's something to look forward to. Just to close, I'd like to say, Bahoma Stusi Sawandanata. Thank you for letting me come to your country. I've had a beautiful week. Thank you very much.
Thank you very much, Tom, for that comprehensive talk on the ocular malignancies. And I just would like to ask if anybody is interested in any questions from the. Well, I would like to ask Tom, like, now, laissez-faire, it's a way forward that, we always try to reconstruct. So how large defect that you would let it heal by itself?
So I've got no hesitation now in leaving full lower lid defects, the entirety of the lower lid. If it extends below the orbital rim, then I'll probably try and advance a bit of skin at least superiorly just to aid the healing. Sometimes it's okay, just to, rather than doing something very, very complex, even if you can reduce the size of a defect by 80% and leave the surrounding 20% to secondary tension, this is an acceptable approach as well. The medial canthus heals really beautifully, and so often I'll leave, 2 centimeter, 3 centimeter, thumb size medial canthal defects to heal by secondary intention. They do great. The only area where you have to have some concern would be we can't leave upper lid defects, of course. Those patients will come to harm within a day or two if you leave them with a full thickness defect. But other than that, lower lids, if the patient's happy, I think it's a good option. I have a PowerPoint presentation. I show my patients. I say, these are your options for what's appropriate, and they tend to choose themselves. So this is that's how I approach it.
Yeah, you're right, about the Hughes and Cutler beard. They don't heal very well. A lot of tension. So why do you think, it has been time tested and people have been doing it for a long time? Why aren't they so successful, compared to?
I don't know. I've only done one Cutler beard in my entire practice, and when I don't really know how I started doing the sliding tarso-cons flaps to fill upper lid defects. I think somebody must have shown me at some point, but that's become my default for upper lid defects. When I want to just, to have a little bit more tarsal plate, I think it works really well. Other than that, rather than Cutler beard, I probably would look to, harvest buccal mucosa, something like that. The Cutler beard I don't think is great. Maybe, rotational flap from the lower lid instead would be something more appropriate. But in my practice, I find the sliding tarso-cons flap is really robust, and it's been a very useful flap.
So there has been talk about, I agree with the fact that, direct closure is very robust technique, it gives results all the time. And now if you have a medial defect, now there's this tendency to lateralize the defect, you close it medially and have space from the lateral side, so it's easily manipulated. Do you do that, or in your practice, do you?
Yeah, absolutely. So it's very quick to divide lateral canthal tendon and create a bit more, mobility in the lid, and then it's very easy to do a little, tensile flap or something like this. So lateralizing things is, the principal local areas where you're going to have redundant tissue are going to be laterally, the glabella, potentially forehead for things like a Fricke flap. But ultimately, the areas that are close to lids that are going to be useful for taking tissue from with flaps is going to be glabella and the lateral skin. So that's where they tend to come from. Maybe sometimes V to Y moving up is quite useful as well.
Brilliant. Any questions from the audience? All right. In the absence of questions, we conclude the session, and I invite Dr. Dushyant Varipula, consultant eye surgeon who has been teacher for many of us, to present a token of appreciation.